yield so I can see. Okay. Neither Dr. Bott nor I have any financial arrangements related to the content of this lecture, so we have nothing to disclose. We're going to talk about components of a team-based approach. So this is really what's recommended in regards to sort of best practice standards for providing not just opiate use disorder treatment for individuals with that are being prescribed buprenorphine, but just individuals with substance use disorder in general. We're going to talk about the importance of using a team-based approach, and then we'll go through the different team members that are recommended, particularly as they apply to running and operating an OBOT or buprenorphine program. Then we'll talk a little bit about the roles and responsibilities of each team member, and then wrap up with how administration leadership can support you in beginning to move in this direction if you're not already. So what does this mean, using a team-based approach? Well, really what we're trying to encourage, which is the best practice recommendation, is developing what are called integrated treatment teams. This isn't multiple providers that are co-located that are serving the patient but not necessarily working as a team. An integrated treatment team are multiple providers from different disciplines that actually work together, that share a treatment plan in how they work with the patient. And this has been well researched and is recommended as the ideal model of treatment, not just for individuals with substance use disorder, but those that also have a co-occurring mental illness, largely because of the really complicated and multifaceted issues that these patients bring to a treatment setting. If you're working as an integrated team, you're more likely to catch those things and be effective at facilitating change. So it's considered the gold standard by almost all regulatory and research bodies. It allows clients or patients to receive treatment for both their comorbid mental illness conditions as well as their substance use and any case management or other psychosocial or medical needs that might present. So all of that care can be coordinated, and those providers can convey a consistent message throughout their recovery process. So there's less opportunity for confusion, less opportunity for things to slip through the cracks. And like I mentioned earlier a little bit, I touched on this, there is a difference between some of the jargon that we use. Although we tend to use the word interdisciplinary and multidisciplinary kind of interchangeably, they really don't mean the same thing. When we're talking about interdisciplinary, we're really talking about the multiple providers that work together versus a multidisciplinary team. A lot of locations will apply this, and this is great. It's better than a single provider working by themselves, obviously, because that's a lot to shoulder for one provider. But interdisciplinary allows those providers to share a treatment plan and to have formulated treatment goals that they work on with the patient, rather than every provider sort of has their own plan with the patient, works a little bit in isolation, even though they may be co-located or located in the same community. So let's talk about some treatment team concepts. So one that's important for all teams to understand is that recovery is more than just symptom remission. It is more than just sobriety. Recovery involves the development of new meaning or purpose in someone's life. And that has been proven by a large literature body that says that individuals will continue to be at relatively high relapse potential as long as they have not integrated into their communities, into their social networks for long-term recovery. So if they haven't transitioned to where they have a reason to get out of bed in the morning. There's a reason for them to avoid those high risk situations. There's no meaning or purpose as to what they're doing on day to day. Then all that they're waiting for is a pretty significant stressor to come along, and it will likely trigger relapse. So for that long-term symptom remission, we really need to help people achieve that level of integration back into their social networks and communities. So therefore, and in order to facilitate that, we need to include all the people that work with the patient and the patient themselves in their treatment plan. If they don't have ownership of what those goals are that are in the service of developing meaning and purpose in their life, they are not likely to actually move forward on those goals. They are not likely to get better. And this requires, I think, support from leadership or administration, because there has to be an infrastructure in place that supports an integrated team, for the team to have cohesion, for the team to have focus and time to do that team-based work. And so there needs to be enough support and time logistically and financially so that those teams can function. And then the expectation is that the treatment teams will use the treatment plan as the fundamental underpinning for clinical encounters. So rather, or I would say in addition to their notes or their encounter documentation, there should also be some time given both during team and also as part of routine documentation to make comments in the patient's treatment plan. The treatment plan should be touched every single time there is any interaction with the patient. So what are the components of a successful team? Well, who's on that team? If we have to break it down, there's two core components. One is the core team and the other is the extended team. So the core team includes the client and all of the primary treating providers. So those that are really on that interdisciplinary team. The extended team are any providers that are in the community or at other agencies that are also involved in that client's care. So that could be their probation officer, that could be a case manager that's working with them on a housing, with a housing agency. That could be, you know, a dentist. That could be any number of individuals that are working with them as part of that extended network. They're still part of the team, but they don't necessarily have to be at every single meeting. So what is the structure? Every team needs to have a lead or a manager, somebody that is at the end of the day, the buck stops here, responsible for the treatment plan and making sure that the team as a whole is working for that client. It also needs to have some sort of coordinator, what's labeled as a recovery coach, who's responsible for organizing the meetings, documenting into the plan, documenting the team-based notes, and making sure that things are tracked accordingly. Now, it's important that all of the members of the team have some defined roles, so they're aware of what is it that they are responsible for when everybody's there, but everyone is sufficient enough at each other's roles that they can be flexible, that if somebody isn't there, that you can fill in. So we all need to be able to know how the team functions and to step into those different roles when needed. But when everyone shows up, we kind of have a defined, this is my role on the team. So let's talk about those different roles. The team lead or team manager it really could be anybody that is independently licensed. So it could be a nurse, could be nurse practitioner, could be MD, psychologist, master's level therapist. They just need to be independently licensed to be able to facilitate. I don't know what just happened. To finish this up, they are a consistent point of contact for the patient. We're still talking about the team lead. And they can coordinate communication across the different team members and with the patient. They may also have some patient care functions. So they may be the prescriber or the therapist for that patient. They may run education groups or do other things. The literature or the research that supports this model has preferred nurses, licensed nurses in this role. Partly, I think, because they are much more available. They don't have sort of blocked out scheduled time the way a therapist or a doctor or a nurse practitioner might have. They tend to be a little more flexible in terms of the clinic workflow. So they're a really good person to put in this role. They can check in with the patient when the patient is there, and they can kind of coordinate all of those pieces, but they are still independently licensed and can sign off on some things. Now, another role that's important is what's labeled as a recovery coach or engagement specialist, and they could be an RN, a community health worker, a peer support specialist, a LADAC. Like this could be someone from that level of training. They would need a little bit of education or experience to be able to really do this effectively, but their role is to be able to link patients to the services and also make sure that we're not missing important deadlines. So they have an administrative role in terms of, checking, was the prior authorization done? Was the PMP looked at? When was the last time they came in? When are they about to run out of their script? Were all of the vital signs done that we normally collect? And then they're also available to provide a lot of patient education about buprenorphine, about expectations of the program. They can do basic harm reduction and kind of one-on-one with folks. They can also run groups that are really skills focused or harm reduction focused. On overdose prevention, relapse prevention. And then they're available to help, check patients in, offer support, connect with referrals, that sort of thing. Referrals, of course, can be made by anybody, and these are a number of the referrals that are recommended within these programs. These would be referral components that would be part of that extended treatment team. Most of these teams are going to recommend that there be a therapist connected, although we know that for individuals with opiate use disorder, therapy is not necessarily the first thing that we're going to recommend for folks. We want them to stabilize on their medication and get out of that intoxication withdrawal cycle before they're really apt to engage effectively with therapy. But it is recommended that therapy be offered throughout the course of their recovery, and particularly once they are stabilized on their medication. If they have other comorbid conditions, particularly, they would likely benefit from therapy. So having a therapist involved is highly, highly recommended. These are the different interventions. They all fall typically under the CBT umbrella, except for 12-step facilitation. But most of these would fall under a CBT or a third wave CBT. And if you have somebody in-house, that's awesome. If you don't, they would be part of that extended team that you would need to have regular contact with them. Your pharmacist is also part of the team, and they're responsible for providing the Loxone distribution, patient education about medications. They can be really wonderful resources for helping to destigmatize and make inroads with our first responder or other community organizations that may have concerns about buprenorphine or patients on buprenorphine. They can also help with education on chronic care management and identifying high-risk patients because they're looking at those multiple prescriptions. And then having an APN or physician assistant that can either be the primary prescriber or can be someone to facilitate naloxone and work closely with the physician who does the initial H&P, assesses for appropriateness of treatment, and provides those buprenorphine prescriptions. Also, they can be very helpful with training and education, not just to the rest of the team, but also to the community. So I think this is where I pass it off to you, Dr. Pott.
Thank you. Yes, Snehal here. Thanks, Dr. Maley. Would you be able to advance the slides, or I'm also happy to pull up my own slides if it's easier.
No, just let me know when you want me to.
Thank you. I'm going to go through them fairly quickly, right? And this is just sort of one idea of how do you use the limited resources to be able to provide care. And this is sort of one model of it, where, for example, prior authorizations, which, thankfully are less and less of what we need to do, as Medicaid becomes more accepting of our medications for opioid use disorder, but sometimes this still comes up, right? So kind of having our provided training to medical assistants or front office staff or even designated staff can really make that process easier. Prior notification, right? So I think, again, very similar to prior authorization, basic understanding of addiction, substance use disorders, how do you work with individuals in a non-stigmatizing way, probably should be all staff, right? Just to create a welcoming environment for our patients. Similarly, handling challenging behaviors and setting appropriate boundaries probably should also be all staff, right? And oftentimes it's the front desk, for example, or the nursing staff that encounter some of these challenging behaviors first. right? Similarly, kind of going forward, some of the specialized ones, follow-up visit protocol, nursing or medical assistant staff in some of the models have carried out a lot of the follow-up visit, as well as the prescription monitoring program. Having someone designated can save a lot of time. So for example, I have four of our nursing staff members are MAs as my designees for the PMP program. So before I'm about to see a patient, they're able to pull the PMP report, the prescription monitoring program report for me, which I can then review, and it saves a little bit of time. Next slide, please. Right. So with that, I think one of the models that really put this idea to use was the Massachusetts collaborative care model, which has been studied quite a bit. And there are many other approaches out there, but this is one that was one of the first ones to really look at it and continues to be one of the ones that's been well studied. Where essentially what they found is that there was a shortage of providers. At that point, it was physicians only who were waived to prescribe buprenorphine. And they really looked at barriers. And one of the barriers that came up was, kind of just that work shortage, right? Shortage of those providers. So they said, well, what if we utilize a team-based model? Would that actually allow physicians to become more willing to prescribe buprenorphine? And would it be cost effective? And indeed, they found that that was the case. Once they really adapted this team-based approach and kind of disseminated it, waived physicians actually went up 375% in a 3-year program as a result of this program. They also found that having a combination of one nursing care manager, which was usually an RN, combined with one medical assistant, they were able to provide treatment to 125 patients, which was financially viable and sustainable. And so what were some of the things they did? So if we can go to the next slide, how did it work? Right, so again, this kind of gives you a little bit of a workflow, right, as part of this collaborative care model. So you can see that a lot of the stuff is actually done by the nursing care manager, including the initial screening, right, including a lot of the follow-up visits, including helping the patient get through the buprenorphine induction process, right, monitoring of stabilization, follow-up. A lot of this is actually done by the nursing care manager. And as Dr. Maley mentioned, RNs are often utilized in this capacity because a lot of the non-billable tasks, they're able to financially, it's just more viable for nurses to serve that role as opposed to the MDs. So if we can go to the next slide, please. And this is just a little reference slide I've included about what the initial screening included. And again, these were things that were carried out by the RN with assistance by the medical assistant. Next slide, please. Importance of training. So the role of the MD, the physician, was a couple of big things. One was, of course, writing the prescription. That was a big role that the MD played, writing and signing off on the prescription, right, and reviewing all the data. The other big role that played was to train, right, providing not buprenorphine waiver trainings, but also kind of buprenorphine 101, SUD 101 trainings for all staff, also helping develop protocols, guidelines, right, and allowing for those shadowing opportunities, clinical support, ongoing trainings, and providing tele-email backup. So almost like a hub capacity, right? So the MD served as the hub. People could call them up, seek consultation. And those were some of the trainings that they provided with the idea of building up the entire workforce. Next slide, please. And the next slide, I believe, is just includes what some of the components of training were. And it's actually, there is a lot of overlap with a lot of the training we provide through this Echo Clinic. Next slide, please. And lastly, just a couple of slides, like administration plays a huge role. If you look at the literature that looks at barriers to prescribing buprenorphine, lack of administrative support often emerges as one of the top barriers, right? So I think if there is anyone in administration, when we often talk about it, really you want to be there to support the clinical team, which can include allowing for regular meetings with open communication, coverage issues, helping create an organized system where providers are able to cover for each other, allowing for appropriate staffing, allowing time for trainings and continuing education, which can just be so satisfying, right, for the for the providers, for the practitioners, for the clinicians in terms of their work satisfaction, and helping create clinic policies and guidelines in conjunction with the team. We do a lot of consultations with various healthcare systems And I can't tell you how much it helps when the administrative support is there. Like if the administration is saying this is a priority, we're helping our communities address opioid use disorders as a priority, it really changes the dynamic, and it's so much easier to work within that system. And providers feel empowered, right, to then also do the things they wish to do. Next slide. And then for all of us, I mean, I think the main take home point here is that something, right, that we all do anyway, but being an advocate for your patients, creating that accepting environment, and really working within community and beyond, not just combat stigma, to really advocate for policies that will ultimately benefit our patients and our communities, right? Including, youth engagement, naloxone distribution, drug take back, funding for treatment, because those things have real world implications. And that's something we all can be doing. And I'll end here. It's about 12:37, so I want to make sure we have